Hi everyone, and welcome to our Wound Care Micro Session Series. I'm Marcus Gitterle, Chief Faculty at Wound Care University and Chief Medical Officer at WoundCentrics. In these short sessions, about 10 minutes or less, we'll tackle one high-impact topic at a time so you can take a practical pearl back to the bedside. Today we are going to discuss hydroxyurea-associated ulcers, a very important but often under-recognized cause of chronic, painful, and difficult to heal wounds. Hydroxyurea ulcers can look like other chronic ulcers, including venous ulcers, arterial ulcers, pressure injuries, or traumatic wounds. However, the key issue is that these wounds often will not heal unless the medication contributing to the ulceration is recognized and addressed. The goal of this session is to help providers and wound care teams identify when hydroxyurea may be contributing to ulcer development or delayed healing, understand the mechanism behind these wounds, and learn how to coordinate care with the prescribing provider, usually hematology or oncology. Here's what we will cover today. We will start with a brief introduction to hydroxyurea and why it matters in wound care. Then we will review the pathophysiology, meaning how hydroxyurea can contribute to ulcer formation and prevent normal tissue repair. Next, we will look at typical wound characteristics and example wounds. These wounds often have a recognizable pattern once you know what to look for. After that, we will focus on treatment. The most important point is that standard wound care alone is often not enough. These ulcers usually require coordination with the prescribing physician for a hydroxyurea hiatus, or what is sometimes called a hydroxyurea holiday. Hydroxyurea ulcers are primarily a clinical diagnosis. That means the diagnosis is made based on the wound characteristics, the patient's history, and the fact that the patient is currently taking or has been treated with hydroxyurea. A biopsy is not routinely needed to rule in hydroxyurea ulceration. In fact, biopsy may create additional trauma to tissue that is already struggling to heal. However, biopsy may be helpful if the clinician needs to rule out another condition, such as malignancy, vasculitis, atypical infection, or another inflammatory process. The key clinical question is, does the wound pattern fit, and is there a history of hydroxyurea exposure? Hydroxyurea is a medication that interferes with cell replication. It is often used to treat myeloproliferative disorders, such as thrombocytosis and other hematologic conditions. The important concept here is that hydroxyurea slows down the ability of cells to divide. That is useful when the goal is to control overproduction of certain blood cells. However, wound healing also depends on cell division. To heal a wound, the body needs keratinocytes, fibroblasts, endothelial cells, immune cells, and other cell types to function properly. These cells must replicate, migrate, create new tissue, form new blood vessels, and support wound closure. Hydroxyurea is used for several conditions, including leukemia, thrombocytosis, polycythemia vera, sickle cell disease, psoriasis, some solid tumor cancers, and other Philadelphia chromosome-negative myeloproliferative disorders. From a wound care perspective, this means we may encounter hydroxyurea in many different patient populations. Some patients may be followed by hematology. Others may have a long-standing history of a blood disorder and may have been on the medication for years. It is important not to assume the medication is optional or unnecessary. Hydroxyurea may be controlling a serious underlying condition. Hydroxyurea-associated ulcers are thought to occur because of cytotoxic effects on epidermal basal keratinocytes and vascular endothelial cells. Keratinocytes are essential for rebuilding the skin surface. Endothelial cells are essential for blood vessel function and tissue perfusion. When these cells are impaired, the skin becomes more vulnerable to breakdown and less capable of repair. Hydroxyurea disrupts DNA synthesis, which prevents normal cell replication. As a result, even minor trauma may become a persistent wound. Hydroxyurea ulcers can occur anywhere on the body, but they are most common on the lower leg and ankle. They are often found over the malleoli, meaning around the ankle bones. By the time patients are referred to wound care, these wounds are often already full thickness. They may have been treated as routine ulcers for weeks or months without improvement. The presentation also notes that these wounds often feature heavy bioburden. Occasionally, these ulcers can involve bone. When a deep ulcer is located over bone, especially near the ankle, osteomyelitis should be considered. On this slide, we are looking at examples of hydroxyurea-associated ulcers. When reviewing images, focus on location, depth, wound bed appearance, and the chronic nature of the wounds. Many hydroxyurea ulcers are located around the ankle or lower leg. They may appear punched out, painful, and full thickness. Some may have slough or heavy surface bioburden. Others may appear stalled despite reasonable standard wound care. These images remind us that hydroxyurea ulcers may mimic other wound types. That is why medication history is essential. Treatment begins with contacting the prescribing physician. This is the central step. The wound care team should explain that the patient has ulcers that are unlikely to heal without discontinuation or temporary interruption of hydroxyurea. The first treatment step is to coordinate a hydroxyurea holiday. This means the medication is temporarily held under the supervision of the prescribing provider. The second step is to continue weekly wound treatment. The medication hiatus creates an opportunity for healing, but the wound still needs aggressive and consistent care. The third step is to monitor the myeloproliferative disorder. When coordinating a hydroxyurea holiday, the conversation with the prescriber should be clear, direct, and collaborative. A useful message may sound like this: this patient has chronic ulcers with features consistent with hydroxyurea-associated ulceration. These wounds are unlikely to heal while the patient remains on hydroxyurea. Can we coordinate a medication hiatus with close blood parameter monitoring to allow wound healing? The purpose is not to criticize the medication choice. Hydroxyurea may be necessary. The purpose is to explain that wound healing may require a temporary change in the treatment plan. Let's summarize the key points. Hydroxyurea ulcers are a clinical diagnosis based on wound characteristics and history of hydroxyurea treatment. These wounds are most common on the lower leg and ankle, especially near the malleoli, but they can occur anywhere. Hydroxyurea interferes with DNA synthesis and cell replication, which can impair keratinocytes, endothelial cells, and the normal wound healing process. Standard wound care alone may not be enough. The wounds often will not heal unless hydroxyurea is discontinued or temporarily held. The most important clinical behavior change I hope you take from this session is to review the medication list whenever a wound is stalled, painful, recurrent, or not behaving as expected. When you identify a possible hydroxyurea-associated ulcer, do not simply change the dressing. Coordinate with the prescribing provider, request consideration of a medication hiatus when medically appropriate, and use that window to provide intensive wound care.
Thank you for attending this wound care microsession. We value your commitment to patient care. We'll be back with another focused topic soon. Don't forget to like and subscribe. See you next time.